Okay, I think we're going to go ahead and get started so that we have time at the end for some questions, I hope. So it's a true honor to introduce our speaker today, Dr. Kimberly Hogewood. I'll tell you, it's really daunting, if not impossible, to sum up her scholarly work and the impact she's had on children's mental health services. Just to give you an idea of what I was dealing with, her CV is 41 pages long, so this is only going to be a Cliff Notes of the greatest hits. But Dr. Hogewood received her PhD in school psychology from the University of Maryland. And so for the students of school psychology here, her career is a testament to the varied, interesting, and important work that can be done with a school psychology degree. She first worked as a staff psychologist in schools and residential centers and then shifted to a career in research, first as a program director for the Texas Education Agency here in Austin, then at the National Institute for Mental Health, where she eventually worked as the associate director for child and adolescent research. Later, she was appointed director of youth services and evaluation research for the Office of Mental Health of the state of New York. And in New York, she's also the director of the Advanced Center on Mental Health Implementation Science in States for Children, Adolescents, and Families, and is the vice chair for research in the Department of Child and Adolescent Psychiatry at NYU. She has co-authored or authored an astonishing 211 peer-reviewed articles, and I'm not including the ones that are under review or in press, as well as lots of chapters and books. And I can tell you I've read probably not all 211, but a lot of them. They're among my most cited and quoted references. So some of my favorite Kimberly Hogewood quotes include 70 to 80% of children who receive mental health services receive them in school. Raise your hand if you've ever quoted that. I think a lot of us have. Another good one, the ethical and scientific challenge for our field inheres in the sluggish movement of effective practices for children and families into the systems that are tasked to serve them. I like that one a lot. And maybe my favorite is, it's difficult and perhaps foolhardy to try to improve what you do not understand. I think I've quoted that like 10 times this year. So please join me in welcoming Dr. Hogewood for her talk today entitled Implementation Research in State Systems for Children with Behavioral Health Needs, Getting in Front of the Power Curve.
Thank you. Thank you so much. It's just wonderful to be here, to be able to talk with you about some of the things that I think are really, really exciting going on in the field of children's mental health, especially in these times which are pretty troubling and uncertain and chaotic, to say the least. But I think we've got some real glimmers of hope. So I'm going to talk with you about the work that is happening both within our center in New York, which is a NIMH-funded services research center in collaboration with the New York State Office of Mental Health. So I'm going to talk a little bit about that, but also give you a sense of what's happening nationally, because I think it's pretty great. And I'm very happy to be in Austin. Thank you, Sarah Kate and others, for getting me here. It doesn't take much to get me here, I will say that. I'm always glad to come to Austin. So some of what I want to talk about is, as I mentioned, is big picture stuff. Increase in prevalence of children's mental disorders and their use of services, the evidence base, which I'm just going to briefly allude to because there's so much there, but the bottom line is that there's a lot of evidence on which to base programs, policies, and implementation. The uncertainty of the current healthcare context has some major implications for how we're trying to think about not just children's services, but also what should be the role of mental health in all of this. And I think these are good questions for us to be asking right now. Pragmatism, what are some practical ways in which we can be helping to improve children's outcomes and family outcomes within the current healthcare context? And then moving beyond that, so how do we get in front of the power curve? I have a real interest in aviation, and I'm a solo pilot right now, continuing to work on that. And power curve, I will give you a little definition of that actually. The power curve in aviation is where you have to remain in order to stay ahead of the plane. It's in order to avoid stalls and the bad consequences of having a stall. And so when you're behind the power curve, that means you're behind where the airplane is and you're in trouble. Getting in front of that means you're thinking ahead of the plane and you're able to keep it, use the aerodynamics in order to keep it moving. And I think as a field in mental health, we have been behind the power curve in many ways. We're reactive, we're trying to clean up problems after they've already gotten fairly entrenched. And if we want to get in front of the power curve, which I think we can do, actually I know we can do it, and I think now is actually a very propitious time for us to be focusing on that. It means to be thinking differently about what we're doing with respect to implementation of programs, policies, and practices. And so I'm going to talk a bit about that. And I'm going to move fairly quickly because I would really love to have questions and interaction. So the national context, healthcare quality and accountability, just some of the key things that have happened over the past 10 years or so. The Mental Health Parity and Addiction Equity Act has been part of the Essential Benefits Package. That's now under fire, may or may not remain, but it has been an important piece of legislation for helping to ensure that people with mental health or addiction problems are able to get this coverage at the same level as they would for other chronic illnesses. The ACA, we all have heard about that. One of the things to keep in mind is that there has been recently legislation passed called the MACRA legislation, which is Medicaid authorization, and it includes the CHIP authorization for children with mental health problems. And that was given support in a bipartisan way. And so it's a very important piece of legislation because it affects the way in which providers are held accountable for the services that they give. It includes an emphasis on both evidence-based practices and quality measures. And it includes an emphasis on pay for performance and value-based purchasing. So I'm going to talk about that with respect to kids' mental health because I think it's important because it's bipartisan, but it's also important because it is very compatible with the work that as a field we've been doing to create an evidence-based compendium of practices. But it affects the way in which things are paid for. So major impact on states, and some of the impact on the states has been the fiscal issues, which I don't need to belabor because we're all aware of them. I know Texas has suffered from that, so has New York, so has every other state. But the way in which states are responding is that more and more of the services are being shifted to Medicaid, to managed care, and that includes Medicaid services being shifted to managed care. And it means both a reduction in many of the community-based services, reduction in funds, but it also means an interest in workforce development. And that workforce development, whoops, let's go back here. The workforce development means an interest in alternative ways of increasing the workforce. In a number of states, ours included in New York, we are looking at parent partners as a part of the professional workforce, have a certification program for parent partners. And there's a national certification as well that still exists and that is being revitalized. But the point is that states and healthcare industry are looking for ways to augment the workforce because there just aren't enough people to provide the services that are needed. And this includes certification and credentialing for people that we might not have thought about in the past as people that can very much be engaged, eager, very trusted partners in the work we're doing. I'm just going to give you a little bit of data about the impairments. Fourfold increase since 1960 in neurodevelopmental conditions and mental health. So it's been pretty much a constant increase. The psychiatric ED visits as a percentage of all visits, those are going up as well. So ED is not the place that you want to send kids and families to for services, but as the community services shrink, this is likely to continue to be the case. Okay, got one of these. And the mental health need and use of services. So both mental health needs as well as use of services have been on the increase. And we'll see if the use of services is going to continue to be on the increase under some of the new healthcare scenarios that we're seeing. But certainly there has been an increase in both of those. So how states are responding, I mentioned the workforce shortages, moving to Medicaid managed care. Departments of health increasingly are dictating the service packages. This is happening in New York. So we're working more and more with Department of Health, which by and large in our state does not have much of an understanding of pediatrics or of children's mental health. So there's a lot of really basic education that we're finding we're needing to do, and other states are having the same kinds of things that they need to do. At the same time, we're seeing much more of an interest in what should states and health plans and payers be measuring. So if they're providing services, how do they know that they're getting their money's worth? How do they know that the services are actually making a difference? And what do those measures look like? And I'm going to spend some time talking about the development of quality measures. So this slide you've probably seen before. You know, when you think about 17-year odyssey from the time of having a finding to the time of actually getting it into practice, that's basically the lifespan of a child. You know, they've pretty much grown up in that amount of time, and that is typically how long it takes from the time that you've got some kind of research finding until you're able to put it into practice, if you're able to put it in practice, which is not a given by any means. And so when we think about the speed at which changes are happening, the speed at which services are being delivered, this is just untenable. You know, we can't have this kind of a gap. We need things that are going to be brief, pragmatic, feasible, effective, as well as cost effective. And that is where a lot of the work is happening right now. So as I mentioned, we have the good fortune to have been funded by NIMH for the past 5 years, and before that we had a developing center. So we've been funded for about 10 years to work directly with New York State Office of Mental Health in order to implement effective practices in the children's mental health system. In collaboration with New York State Office of Mental Health, we have a community TA center, CTAC, which has given us access to all 340 or so child serving clinics that are part of agencies that are providing services to kids and families. So it's an incredible laboratory for trying to understand better how to both provide technical assistance, help improve the practices, and study them at the same time. So we've been very fortunate. Our Community TA Center has focused both on implementing particular evidence-based practices, and I'll talk a little bit about the Evidence-Based Treatment Dissemination Center, where we're implementing the MAP project, Managing Adapting Practices of Bruce Charpita and others. And we're also focused a lot, not surprisingly, on business practices. So for somebody who's a school psychologist by training, and my partner in this has been Mary McKay, who's a social worker by training, to move into the business practice realm has been a real education. And so what we did was we brought in people that had been the heads, the CEOs of some of the major agencies to help us think about it. We worked with the National Council on Behavioral Health to help us think about business practices and how to provide technical assistance to these clinics and agencies that are drowning in regulations. Many of them are going under. Many of them are merging. And so there's been humongous changes that are happening in the service network. But what we've done is we are providing now business improvement practices through webinars, through learning collaboratives, through individual consultation. And we find that that has got to be done at the same time as we're doing the clinical practices. And if we can't marry those two, then we're just spitting in the wind because none of the clinics are going to listen to us. They need to know how to stay viable and stay alive. So this includes open access, centralized scheduling, concurrent documentation, volume and productivity, et cetera. This just as an example of how beleaguered the clinics are, the yellow is the target amount of funds that they should be getting per billable hour. So that's what they need to stay alive. And the green is what they're actually bringing in. So all but one of the clinics in this sample are hemorrhaging. You know, they are just plain dying. They don't know how to bill for the services they're delivering. They don't know how to capture the costs appropriately. They don't know how to engage the families. So these kinds of data point out to us where we need to be directing our efforts when it comes to not just teaching them how to stay in business, but also what kinds of clinical practices to be able to deliver so that you can get the outcomes. So what we have been focusing on is the Evidence-Based Treatment Dissemination Center and the MAP rollout. And I'll just show you a few slides of some of what we've been trying to do with this. This was funded by OMH in 2006, so we've been going now 11 years. And it started, actually it started before that, started in 2002, right after September 11th. That was where OMH got first involved in saying, we need to do something to deal with trauma. The trauma after September 11th. So how can you help us develop a model that's going to be able to train clinicians, frontline clinicians, be able to address the trauma for children and families? And so that was where we first got started in trying to develop a model, and it's evolved over time. We're now doing the MAP training and have been doing that for a few years now, since 2013. And it involves a model of training that I'll just spend a couple minutes on, because it is an adaptation of what Bruce and his colleagues have done. He's been a wonderful colleague in saying, here's the model, do what you need to make it work in New York. And so that's exactly what we have been doing. So we have a combination of in-person training, midpoint checkup, consultation webinars now for 4 months, and certification materials. And what we found was, and these are the clinician certification that basically is very similar to what Bruce and his colleagues have out in Los Angeles. But the reason that we had to, well, before I go to that, current training over 50, and we've had 203, and our passing rate right now is 95%. But the reason we had to do that is because our initial training model was not working. MAP version 1 versus MAP version 2 just shows you some of the differences. We initially had 2 days of in-person training, 3 days of webinar training, no midpoint. We had 9 months of calls. We had 14 consultations. We had about 8 to 10 clinicians per group. And what we were finding is that we were losing most of the clinicians. They were dropping out of our training. They weren't completing the certification requirements. So we were losing people at a great rate. And we didn't want to do that. There's too much of an investment. So we adapted our training model to make it longer when it came to the in-person training, more face-to-face time, less webinar training time, having a midpoint meeting. But the main thing that we did was that we gave them very individualized IT support. So the thing that was, when we went back to ask them, why the heck are you dropping out? Why is this not working for you? It had to do with the measurement feedback system, the dashboard, which was very simple in our minds. It was an Excel spreadsheet, and they could upload any number of outcome measures, but it was daunting for these clinicians. They were not able to do just the simple use of the dashboard. So we individualized that kind of IT support. And what we found was major changes. So our dropouts went from half, 51%, to 12%, 12.6%. Our submitted portfolios went from 35% to 100%, and the passing portfolios also went up. And we think that it was the combination of more of that individualized face-to-face time, and in particular, the very specific individualized support around the use of the IT system, the measures and measurement feedback system. So we're continuing to do that work in the state, and continuing to tweak the model. But right now, it's something that has been very well received, and we continue to have clinicians signing up. But it's an example to me of the way in which you can be both pragmatic as well as true to the clinical model, and be able to help engage clinicians despite the burdens and the problems that many of them are facing. We're moving now, in addition to the EBT training, we're moving into quality measures development. And I'm going to spend a little bit of time talking about that, because I think it's both, it's really important stuff, but it can sound like, jargon, and it can sound like a lot of labor for nothing, almost. But to my way of thinking, if we can get are thinking around quality measures right, we will have our finger on the drivers for change. And so to me, the quality measures work is some of the most important work that as a field in children's mental health, we should be paying particular attention to. The reason that quality measures are important is because they are used for accountability standards and for monitoring the effect of programs more and more. So they are part of the pay-for-performance model, where the payer, in this case the state, in my case it's states, but it could be any payer, is targeting very specific measures. The health plans are incentivized then to be able to show change in those measures. Some of these health plans have clinically integrated network contracts, and the physicians or the providers are also incentivized to be able to perform according to these metrics. So they are the main drivers for how money is going to flow and what will be considered a positive outcome. Now, the truth of the matter is that right now there are less than a dozen quality measures in pediatric behavioral health for kids that have been tested, that have been vetted, that are part of the HEDIS system. And that's in contrast to about 650 adult measures. Now just think about that. There's been so much effort to develop the adult measures, very little effort to develop or test these child measures. And yet, if we are not doing that as a field, somebody else is going to develop them, and somebody else is going to say, you're being held accountable for this, that, or the other. So we ought to be getting behind this in a big way and getting it right. So I'm going to talk a little bit more about what that might look like. So what are quality measures? Well, they quantify structures, processes, outcomes, and perceptions of kids and families. They're associated with health care, and they follow the Institute of Medicine, which is now called the National Academies of Science, Engineering, and Medicine, principles of they're effective, safe, efficient, patient-centered, equitable, and timely. Those are the IOM principles that all health care is trying to abide by. I'll talk a little bit about how they're developed. We've had the opportunity to work with the National Committee on Quality Assurance, NCQA, to develop some measures around adolescent depression. We've also developed some on access to care, which I probably won't have time to go into, but can talk about that later. And then there are a whole slew of other areas that are now being targeted for development. Now, the development of these it takes a while. The reason that they're important is because our health care in this country is very costly, and it's not leading to the outcomes that we all hope would be the outcomes. But we focus on adolescent depression as a start because, as you all know, this is prevalent, it's disabling, it has long-term consequences for kids and families, and most kids are not receiving appropriate care. So it seemed like this would be a good place to begin in developing the quality measures. The process of that involved a very thorough review of the literature, of course, so looking at what's the evidence base on screening, what's the evidence base on assessment, what's the evidence base on different types of treatment models for adolescent depression. And if you were to conceptualize an ideal system, and that's part of the sort of mental model that you engage in, if you were to develop an ideal system, what would it look like? Well, you'd have children screened, adolescents screened. Then there'd be an assessment. You'd want to assess for suicide. Then there might be a brief supportive counseling. There'd be a symptom reassessment, remission, and then you'd go into different kinds of treatment options. So this is the map of what it should look like, and this was published in Pediatrics a couple years ago. So on the basis of that, the quality measures were developed, and they have the measure concept, which is those 9, I think it was, boxes. And then there's a denominator, so where are you going to be getting the data from? In this case, we were using health records. Some places are using Medicaid data. There are different ways to do it. And then what would the numerator look like? So it's being very, very specific and precise about all of these different concepts. And then when we've done some testing of this with NCQA in 3 different sites, one was an FQHC, Federally Qualified Health Center, another was a large group practice, and another was a sort of medium-sized group practice, we can see that the performance rate simply for the monitoring measure was all over the place, from 30% to 70% to 73%, and the overall performance rate was 64%. So that this helps the health plan decide where do they need to be targeting their efforts in order to get that performance rate up. So it's a way of being very, very specific, using data that's out there to be able to say, these are our targets for change. In this case, we want to change screening, or we want to change monitoring. This is where we're at. This is where we need to go. So when we think about quality measures in the sort of new healthcare front and where the trends are, the interest right now is in developing collaborative care models that are going to be able to contain costs and improve outcomes and use quality measures as a way to drive some of this change. So collaborative care has been developed in the adult area for many, many years. There has been some work in the child area based on Wagner's chronic care model, which has the types of elements that you would always want to have in any kind of consultation. So access to consultation, clinical service, communication, coordination. In a way, it's like a wraparound model as well. There has been a very, very well done research synthesis of collaborative care models in pediatrics for both mental health and for substance use. And basically, the main contributors to that have been David Kolko, Jonah Sarno, Laura Richardson. And so there have been 3 real models of collaborative care where the effect sizes have been strong, the changes between the group that was getting the collaborative care model and those that were getting usual care were robust. There are other ways of integrating, and you can see in substance use the effect sizes are actually much less, so they have a longer way to go, substance abuse treatments and collaborative care approaches. But the point simply is that despite the fact that there's a stronger evidence base on the adult side, there's plenty to talk about when it comes to kids' collaborative care models. Now, these have been limited in their implementation thus far because they're still pretty cumbersome, but that is changing. There is work being done to make them more feasible and to make them easier to implement. So collaborative care models are one of the ways in which accountable care organizations are thinking about delivering care. And accountable care organizations are large organizations of healthcare entities that are designed to be able to provide services for a particular population and control the costs and be able to improve the quality. From the federal standpoint, the Center for Medicaid and Medicare Services, CMS, has had guidelines for what adult ACOs might look like. They have never had any guidelines for pediatric accountable care organizations, but these are going to happen. They're now actually requesting input on what those guidelines might entail. So in terms of where healthcare is moving in the future, ACOs are likely to be one of the ways in which we're going to see healthcare coordinated, paid for, accounted for. And for kids, we need to be thinking about it differently than we do for adults, as usual. But there are groups that are now synthesizing the evidence on what exists in order to be able to develop some models and be able to test them further. One such model is a pediatric health home with stepped behavioral health services and integrated community-based supports. And it's shown a reduction in costs in a 5 to 7 year time frame. So there's some good news that's out there right now. Sarah Kate and I were just talking about Ken Dodge and some of his work, and this comes from Ken's analysis of many data sets about measuring children's developmental outcomes within could be within pediatric ACOs, but he was focusing on measuring these outcomes and what does it take to be able to delay initiation of substance use, for example. So this is based on a lot of data that shows that if you target some particular areas of concern, child factors, sociocultural context, early parenting problems, etc., then you're able to delay initiation. Now, why is this important? These are the kind of data that are being looked at to develop plans for what should be measured in order to be able to move services upstream, so getting in front of the power curve, to be able to offset the costly trajectories that happen when services do not reach kids and families in a timely way. So this is an example of a model that helps to direct the way in which people are thinking about what should be in these pediatric ACOs. So some of the types of measures for tracking children's development that could predict later savings: children's cognitive, affective, behavioral development, and the key risk and protective factors. So these would be some specific tools that are sensitive to intervention effects so that you can see a reduction in risk over a short time. So in other words, your healthcare provider could be, in a new scenario, held responsible for tracking these kinds of changes, with the argument being, if you can show improvements in cognitive, affective, behavioral changes, then you as a healthcare entity are helping to save costs downstream. That's the logic of it. Measures that track points along individuals' development, so things like attachment, bonding, limitations on adversity. So healthcare providers focusing on these, focusing on kindergarten readiness at age 5, grade level reading at age 8, social, psychological, cognitive development through high school. These are specific areas where people are looking for tools, where the idea is healthcare entities, providers, contractors, and states would be held accountable for making sure that they're focusing on kindergarten readiness. Now, that's not happening right now, right? We know that's not happening. But if that was an expectation, then the argument is we'd be able to prevent the longer-term societal costs as well as individual costs to kids and families. There are also discussions about population-level approaches, so having communities be responsible for tracking these kinds of larger social issues. We as a mental health field have not been thinking along these lines by and large, right? We're thinking about individual change, individual effective practices, and that's very important. I'm not dismissing that at all. But this is enabling us to think in a broader way about where we could be putting our expertise and our efforts to help support a focus on some of these early intervention approaches that, for which data are quite compelling, it can prevent later costs to society and to individuals. Some of the potential tools that are being discussed: safe environment for every kid, parent screening questionnaires, SDQs, et cetera. But these are some of the ones that are being proposed to be used as part of the quality measures for healthcare providers. An example of use: minimizing perinatal maternal stress, decreases in some of the PSQ scores or adverse childhood experiences. Even one ACE reduction, adverse childhood experiences, can have major effects on tobacco use, obesity, other healthcare concerns. So the point, again, is to say, as a mental health field, can we be using the expertise, the knowledge, the research base that exists to help get more precise and refined in the way in which we're thinking about the types of outcomes that matter and what our healthcare providers should be focusing on, and what we as families and mental health practitioners can help support. Another example: improvement in social emotional kindergarten readiness, and that's associated with a number of healthcare expenses long term. And so this is the case that is now being built. And to me, it's a really important development, because it's using knowledge that has been around for a while to amass it in the service of helping kids and families, doing it in a healthcare context that by and large has been more reactive than proactive. And I think there's some real possibility for positive change here. So, getting in front of the power curve, To me, this means implementing both policies and practices. If we continue to focus from an implementation science standpoint just on implementing effective treatments or practices in various systems, that's all well and good, but we're not going to be able to make the strides that I think we can make and we should be making. And in order to do that means that we need to be thinking about mental health not simply from an individual standpoint, but from the idea of communities, the collective efficacy of our communities, and can we take the work that we have and build that into stronger community partnerships. Collective efficacy came from Rob Sampson and Felton Earls 15, 20 years ago, I guess, from the Chicago Project. I think it's a very important construct that can be resurrected to combine that with family strengthening approaches in order to be able to make some of these changes at a social level in our communities that are going to help kids and families over the long haul. So in conclusion, the anti-federalism and the devastating cutbacks to the safety net are requiring us, I think, as a field to rethink what we mean by mental health and where we want to be putting our efforts. So are we going to be trying to say mental health is different, we're separate, we need to protect our separate system, or do we want to say we're part of a public health framework and can we put our expertise into play to help improve communities, networks, neighborhoods, larger social groups where we have not necessarily focused as much of our efforts as we could. So a public health approach means paying attention to collective efficacy. I really do think that literature is critically important and very valuable, especially if it's linked with family strengthening and parent partnerships. We know community social contexts influence health outcomes. We know there is a social gradient of education and income in this country where the wealthier you are, the more educated you are, the better the health outcomes for kids and families, and the opposite holds. That has been clearly demonstrated. So can we be focusing now on social policies and upstream services to get ahead of that power curve, to get ahead of the plane so we don't crash and burn, and support families and communities, means supporting policies that are going to level that social gradient. And these include policies that we haven't paid much attention to: earned income support, housing, employment. These are some of the social policies, many of which are under siege right now. But at the same time, there's an effort in being able to say, can we develop a better health care system that is going to be able to take care of everybody within it? And that includes kids and families, and it includes kids and families where kids are still young and are developing. So can we be thinking about our contribution within that broader framework? I think we can. I think that's where mental health needs to be. I think that's where we can make a big difference. And I think now is a very, very propitious time for doing so. Despite what's happening federally, this is where the power of communities and of families to take the knowledge that we have and put it into action can really make a difference. There's a wonderful book I've been reading. I highly recommend it if you haven't read it, Rebecca Solnit in Hope in the Dark. And she's updated it a bit for our current times, but she's a historian, and she traces the history of collective movements over time and the changes that have happened as a result of small incremental changes that often we don't even see. We're not even aware that they're happening, but they are, and how they lead to bigger changes in the future. And she says we write history with our feet and with our presence and our collective voice and vision. So thank you once again for having me. And I think we have time for questions.
We do. We have
Good.
quite a bit of time.
Good.
So I have a microphone, and if you have a question, I will come to you with it. This is very exciting. I did my internship where Dr. Hogood was back in the day, and we were both reminiscing about how at Grand Rounds, if you had a question, the chair of child psychiatry would come over to you with a microphone. So I feel really...
And even if you didn't have a question.
Even if you didn't have a question, he thought you looked like maybe you wanted to say something. So this is my moment to enact that. So don't let me waste it. Give me some questions. Yeah.
Okay, this is so strange. I guess I'm curious, like, with the Affordable Care Act, what you thought was the biggest change, like positive outcome that did come out of it that we may be able to sustain even with the change in healthcare policy.
Yeah, that's a really good question. Well, I think that, it was primarily coverage for people that didn't have coverage. That was what ACA did, was provide the insurance coverage. And so I think the fact that so many people who had been uninsured, including kids and families, were insured is a big change. The other was a big change and continues to be important and is still being fought for. The essential health benefit, I think, is another one which provided the mental health coverage. And that one is up in the air, whether that's going to remain or not. The MACRA legislation was a kind of offshoot of ACA. That, as I mentioned before, has the bipartisan support, and that is likely to continue. And much of what I was talking about around quality measures, around the focus on population health and community measures, and value-based approaches, and developing drivers, that right now is intact, and it doesn't look like that's likely to change. So that's where I'm thinking we need to be putting a lot of our efforts. Quality measures, cost offsets, evidence-based treatments and practices, brief fidelity measures. I think those are all going to continue to remain important because they tend to be something that meets a lot of different needs. If you're trying to save money, you can do that. If you're trying to improve outcomes, you're going to do that. If you're trying to be precise about what kinds of outcomes, you can do that. So I think MACRA, I think the Medicaid changes that are being under review at CMS, I think a lot of community action too. Even if all of ACA were to go away, which hopefully it won't, but let's say it were, there's so much that can be done, and right now I'm seeing a lot of community efforts to develop their own ways of measuring what's happening at a local level. That's all good stuff, there's a lot of energy there. So I really think, despite what's happening at the federal level, there's much that can be done at both states and at local communities. I remain optimistic. Yeah.
I think we want it for the video, so I will rush to.
Thank you.
So I was wondering what your thoughts are about sort of the additional skill sets that trainees should develop to be able to extend this field of mental health to interact more so with policymakers, because it strikes me that perhaps the more traditional training for mental health providers has less of a focus on that unique skill set or separate skill set. So.
Yeah, that's a very, very interesting question. There was a recent, I still want to say Institute of Medicine, but it's really National Academy of Sciences forum. And National Academy of Sciences is a independent entity that receives funding from different agencies for different projects. And so it basically is independent of politics, which is a good thing, and very scientifically based. They had a recent forum a few months back on the credentialing and certification process for the workforce to be able to support pediatric, they call it CAB, cognitive affective behavioral health, so children's cognitive affective behavioral health. So you had pediatrics, psychology, social work, psychiatry, parent partners, and credentialing there. And everybody, all of these disciplines sort of had their own credentials and expectations about competencies and skills. But what was very interesting is that what seemed to be connecting all of them was a focus on collaboration, on the ability to collaborate within a team. And that isn't something, I think, as a field we have spent that much time on. We sort of take it for granted. We're psychologists, we're good people, we're nice, we're inviting, so we're going to be able to collaborate. But there's actually, to be able to think about role definition, about the boundaries of what you're doing and what others are doing, on how to create a collaborative team. I think if I were to select some of those areas of competency building, that's exactly where I'd be, because that's where health is going. That's where I think mental health should be.
I'm wondering what you think the role of schools is in this idea of expanding mental health into more of a public health community setting, whether that's maybe more identification or service delivery, or how that might fit into this bigger picture.
Yeah, excellent. Well, schools are core to any community. You know, they are the core when it comes to kids and kids' job, so to speak. Being in school is the role of kids. I think the fact that the Vital Signs Project of the National Academy of Sciences, the accountable care organizations that I was talking about, that CMS is looking for, guidelines for pediatric ACOs, that they are focusing on school issues, kindergarten readiness, ability to read, you know, achieving grade level at various points. That is where these are going to be measures that are going to be used for tracking the health of the population as a whole. Schools are vital to that. So I think as we're thinking from a mental health standpoint, how we can help support what schools are doing, it's going to be around some of the traditional academic measures, which are likely to become benchmarks for assessing the health of communities. So I think there's a huge role for schools. I don't think it's something, you know, as school psychologists, and I know all of you are, or most of you are familiar with that way of thinking, it's been largely around consultative models within the schools, supporting families, supporting kids' education. I think this opens up another new door for us, frankly, to be able to think about quality measures, community and population level measures, and making sure that the work we're doing to strengthen the schools is being used as a benchmark to show the improvement for our communities. So I think there's a lot that we can be doing. Actually, now is sort of the time for us to be stepping out and saying, we want to be part of these discussions within the community on population measures. Robert Wood Johnson has a big, I think it's 200 counties initiative. They also have another initiative around collective supports for states and for other large entities, and they're focusing on what should we be measuring? How do we know if communities are thriving? What should be our measures? And more people are saying, for kids, it's got to include school. So we should be thinking about these broader opportunities to have an impact, and I think now's the time.
So I like how you talked about using business strategies to increase compensation for non-billable hours and engaging the workforce. What ideas do you have, or even if this is a good idea, about accessing the private sector for some of these, some monetary support, instead of ever having to rely so heavily on federal or state support and dollars? For example, a lot of large businesses in Austin, have you ever thought about going to some of these large software programming and talking about, this is the community in which we live, this has value for your company?
I think it's a great idea. And there are some examples of groups that are doing that. In Columbus, Ohio, for example, where they have a lot of private businesses that have their headquarters there. Nationwide Children's Hospital has created a consortium with some of the businesses to take responsibility for some of the neighborhoods around the hospital, actually. And so it's a consortium of both private businesses, the public sector, so Ohio and Ohio Medicaid is there, the hospital, as well as community providers. We've been working with them around training parent partners to be part of the mix. And so they all are working together on a few specific goals. They want to increase the employment in the neighborhood. They want to increase the school readiness, as I was mentioning before. So I think there's a huge role for private industry as well. It means being real clear about what is the goal, what are the boundaries, and a pooling of resources so that no one is beholden to just one funder or another. But I think there's a real opportunity, as an example of what can happen at more local levels. And they've written up the Nationwide Children's. There's been some work on that. Kelly Kelleher is the lead author on that, I'm pretty sure.
In our state, we do have certification for family partners or parent-peer partners, and but they're not yet recognized in Medicaid in the state plan. And there is a current bill or two bills in our legislative session to look at that. Any guidance or advice about how to make that argument effectively in tight financial circumstances?
Yeah, yeah. We're sort of in the same situation in New York, so it's going to be part of our state plan, the parent credentialing, and we think that it's going to be something that will be billable, but we're not quite there yet. You know, I think we and a group called FREDLA, you may be aware of, is compiling all the data that they can on the ways to make the strongest argument. We don't have a whole lot of good cost offset data right now, so I think a lot of it is likely to, could be strengthened if it's linked to some of the data I was presenting about what you can do with families to strengthen them at an early age for kids and the long-term offset, so reducing ACEs. You know, I don't think there have been any studies I'm aware of parent partners focusing on working with ACE reduction, adverse childhood. But even if we made a somewhat tangential argument or a little more tenuous, I think that you could make an argument that that is what parent partners are doing often. That's supporting families, is helping to reduce the parent stress, which is helping to reduce some of those adverse events, or at least help them navigate. So I think that's one idea. The other is I think we can make an argument for improved networking that parent partners do. And there's some good data from Mark Atkins' group about networks, and when you create those networks, how that helps support families and reduce costs. So I think we have to do it a little bit, you know, be creative, but I think we can. It's data there from other sources.
I was just wondering if you had any thoughts out of the Cures Act that had passed in December, which had a lot of things, but one of the things was pushing NIMH and SAMHSA to be better aligned like they supposedly used to be. But of being able to break down, you know, when you talk about it takes 17 years for it to actually end up in practice, what do you think needs to happen to actually fix that issue?
Fix that. From a NIH standpoint, or?
Well, I think that was one of the goals with that, was saying that SAMHSA and NIMH needed to better be partners again.
Yes.
I don't know if they ever really were great partners, but
they were.
That was one of the parts of the bill.
Yeah. They were stronger well, they were administratively together. Yeah. And actually, when I went to NIMH, they were just separating. It was right at that point. I have a lot to say about NIMH. NIMH's priorities, I think, have not aligned with where I think they could be making the most impact. And we've been tracking the trends in dollars for children's services research, and it's just, you know, taken a nosedive. I think there are a number of things. I think one is having some priorities around research that's policy relevant. I think that's what's needed. I think connection with SAMHSA, insofar as you had if SAMHSA could create, frankly, what I think we've been able to do in New York, which is have the service support and then put the research on top of that, it creates that partnership. And so I think there are opportunities for doing that. NIMH in the past has had things they call rapid awards. So it's a way to speed up the cycle, something that's policy relevant. Somebody's got a great idea, there's this opportunity, but they don't have the 2, 3, 5 years to, you know, get the grant. Can you do some rapid grant awards? So I think that's something that could be reinstated around some key areas. There's a lot that could be done. I think with the new director, there's an opportunity there, and I know that they're looking for ideas around some of some key areas. So that doesn't necessarily completely address it, but I think there's, yeah, I think there is opportunity. Yeah, I think there is. I think SAMHSA would need to get more specific in what its priorities are, and I think NIMH needs to get a little wider, frankly. So there would have to be a real meeting in the middle. But it could be done.
Something I always think about when I talk about these topics is that the onus is on mental health providers to make this happen. Like even like from like technical support, which is something like I find like in my own research, like as a psychologist in training, I'm providing a lot of technical support, you know, and doing like those things as well as the services, as well as this, you know. So that's like the social workers, the psychologists. What about the medical providers, and like what changes have you seen in the last like 10 years in their approach to integrated care, and how can we make that better?
Yeah, there's a long way to go there. I think that the traditional medical training has not been very helpful for the work that we're talking about right now, frankly. But I think, again, the models are changing because the incentives are changing. So the slide I showed where medical providers are incentivized to follow certain practices, that is happening more and more. There's some interesting data about solo medical providers, how very few there are that medical providers are now being put into larger group practices. Those group practices, in order to stay alive from a financial standpoint, are going to need to have pay for performance and quality measures. Those quality measures are going to require collaborative teams, which is what I was talking about before. So sort of kicking and screaming in some cases, I think the changes are going to be happening. And there's a group, a consortium of pediatric hospitals around the country, several in Ohio, Pittsburgh, et cetera. I don't know if Dell is part of that, but boy, it sure would be cool if they could become part of this consortium, where they're very much looking at similar tracking of outcomes, collaborative models, pay for performance approaches, everything that I've been talking about. But within these pediatric hospitals that are now being held responsible for what's happening in their communities as well. So I think things are changing. It's been a slow process, but I think when the financial incentives change magically, that changes behavior too.
We have time for one more. I'll come this side of the room. I'm so happy. I was worried that I was ignoring you by standing over here. I know.
This is a follow-up to the two previous questions, really, and I was so glad to hear you ask that one because and not to put you on the spot, you've done extensive research on the policy end, the clinical practice end, the family perspective, so you've really looked at all of it. And as someone who works for the National Alliance on Mental Illness, your data supports what we've known as family members all along, which is collaborative care works. We need the integrated system, but also as a recovering mental health clinician, the rubber really does meet the road with this group here in the room with what they're going to do when they actually get into the field. All of that said, my question is, and that 17-year trajectory is terrifying, but it's reality. So when you have a finding to implementation 17 years, but then you've got the backtracking of training people, training new clinicians to do what we know works, what recommendations do you have for those of us in the room and our networks? What can we do now to support the changes that, because we're on the cusp of so many different things, and some of the incentive is coming from what's being pulled out from under us with what we know is going to change. It's just a matter of how is it going to change. What's your best recommendation for us now to shore up the potential good things that can happen and try to expedite some of that?
Yeah. Well, Terry. Yeah, that's.
But what do we do now? What can we do now? You've got people who are about to go into
Develop local coalitions. Develop those local coalitions and get people that are in a position to be able to make changes at a local level, agreeing on what do we want to change, how do we want to measure it, how can we align the people that are paying for it, how do we make sure parents are their voice is heard. I had the opportunity to work in Sandy Hook in Newtown, Connecticut, a few years ago, and it was a few years after the horrible shooting there. And part of what they were trying to do is rebuild their community. And so there are some blueprints, some maps. Neil Halfon has some, Communities That Care have them, Dartmouth has some, of how do you build those community coalitions to be able to be strong and solid, to be able to have the connections among the providers, and to be able to track what you want to change, and be able to have the police and the social services, et cetera. So I think we need to be thinking on more of a local level right now. Austin has done that for years, so I'm saying, you know, I think Austin is actually a really amazing example of that. But I do think that that's what we need to do, and that's where the training of sort of the future practitioners can be made both relevant and practical and rigorous too, because we need the input on what to measure, how to measure it, how to use data to make those changes stick. And I think if we can be thinking about the measures, thinking about the data, and thinking about those collaborative connections, then we can make a difference, even if it's just within our neighborhood. But those things trickle out, as Rebecca Solnit said. They trickle, and they make a bigger difference down the road. That's my best advice at the moment.
All right, well, that's a great note to end on. Thank you again, and please join me in thanking Dr. Hogewood for coming to Austin.